starting from the basics. And we have Eswar here, and he's going to talk to us on preoperative investigations in a case of cataract. 7-minute talk, okay?
Good morning, everyone. I'm Dr. Eswar from Sushila Netralaya, Kurnool. I thank AOS for giving me this opportunity to present. And my talk is on preoperative investigations in case of cataract, and there are no financial interest. I am dividing this topic into two parts, systemic investigations and ocular investigations. Coming to systemic investigations, for the routine investigations, we do viral markers, RBS, blood sugar, blood pressure, ECG, and Xeroconn sensitivity test. Viral markers are very important because it has been seen that so many instruments we use are going to get contaminated with the viral particles when we do surgery on a patient having these problems, and it has to be done because to protect ourselves for the healthcare workers to prevent these diseases. And coming to blood sugar, AIOS guidelines are around RBS less than 200 milligrams per deciliter is the most important thing. For AIO guidelines, it has been said that FBS 90 to 130 milligrams and PPBS less than 180 as a consideration for blood sugar. Why blood sugar is important? Because we know if the patient is having hyperglycemia, they may have wound infections and the wound closure will also be delayed and it may be very problematic. And blood pressure is very important because if the patient is having hypertension on table, he may land up in any complications like cardiovascular events and neurovascular events. So checking blood pressure on before surgery and before in the preoperative itself is very important. If the patient is having less than 180 by 110, it is considered as better option. We can go with the elective surgery. If it is more than 180 by 110, it's better not to do the surgery and control the blood pressure and do the surgery. And ECG should be done when the patient is having symptoms according to cardiac history, and ECG echo should be done when the patient is having cardiac history, and there is no need for routinely doing for cataract surgery. Xeroconn sensitivity test is very important because if we do inject for peribulbar block, if the patient lands up in anaphylactic shock, it is very drastic emergency thing. We should give immediate response to treat the patient. So doing Xeroconn sensitivity test before surgery is most important. We must inject 0.2 ml of Xeroconn with hyaluronidase because even hyaluronidase having allergy to so many patients, so we have to give better hyaluronidase and lignocaine half an hour before. Okay, for pre-senile cataracts, it's in the OPD settings. We must check about serum vitamin D, dyslipidemia, and smoking history. It will tell us about if the patient is having any cardiac, any other symptoms also. Complicated cataract, there is some complete so many investigations that should be done so that we can protect the retina as well as systemically, so that we have to give the systemic treatment or just ocular treatment is enough or not. Congenital cataract, the patient may be having any CNS issues, CVS issues, systemic issues, so better to do all this battery of tests so that it's better to help them systemically also. Ocular investigations, these are the tests I am going to talk about. And coming to syringing, Roplas is the thing which we can do in the OPD. Lacrimal syringing is very must because the patient may land up in endophthalmitis if we don't do the lacrimal syringing. It's a drastic complication any cataract surgeon can expect. So meibography is very important because we see where the ocular surface is not good, the patient may land up in refractive surprises, and the patient may not be happy also post-operatively because of the dry eye symptoms will increase more after the cataract surgery. And if you can see over here, the keratometer readings are, we can see in the map also, there are some abnormality in the anterior surface when the IOL power is 20, but when we treat the patient for dry eye, we may land up in refractive surprise also. The IOL power is 21. So the FACO study has told that it's better to treat the ocular surface beforehand, before going to cataract surgery, then we don't land up in refractive surprise and patient will also be happy. And keratometry is most important by doing tomography and topography because we can measure the astigmatism. Depending upon the astigmatism, we can go to the toric IOLs, and if the patient is having corneal ectasias, which may not find out through slit lamp, if may be in a hurry or something like that, even with slight differences in the corneal ectasia can be treated by doing the tomography. And post-refractive surgery, if you do post-refractive surgery, IOL formulas will be different compared to normal things. Sometimes patient may be not telling in the history, but we can identify it by seeing the tomography. And corneal higher order aberrations must be checked because if the corneal aberrations are not checked, the patient might have less contrast sensitivity, and they should not be having, they must be having a lot of glare and halos. So we must not go for multifocals and toric IOLs or EDOF lenses when the patient is having high corneal astigmatism, higher order aberrations. And by seeing the topographic pattern, we can identify the refractive surgery the patient had, and if the patient is having corneal spherical aberrations positive, if negative negative corneal spherical aberrations, we can go with spherical IOLs, and vice versa. If the corneal spherical aberrations are positive, we can go with aspheric IOLs, and depending upon the corneal astigmatism, we can go with the toric IOLs. Specular microscopy is also an important tool to be done beforehand, because we may identify any corneal issue, endothelial issue is there not. Either we have to go directly with the cataract surgery, or we may have to do endothelial keratoplasty along with cataract surgery. Ultrasound biometry is most important in calculating the IOL formulas. Previously, ultrasound biometry is used. Immersion scan is much better than the contact scan, and optical biometry is better than the ultrasound biometry. And these are the tools which we use daily for optical biometry: sub-source OCT, partial coherence interferometry, low coherence optical reflectometer. And it has been said that compared to others, sub-source OCT is much better compared to partial coherence interferometry and other things. And these are the IOL formulas which we use, and the recent AO guidelines is saying that Kane, Olsen, and Barrett are the best for any type of cataract surgery or eye, so that we can get the better outcomes. B-scan is must when it is a dense cataract with too much PSC or mature cataracts, we can't see opaque media. Like in this case, we can identify RD, we can identify the posterior staphyloma, we can identify the intraocular foreign bodies, and it's in a case of dense vitreous hemorrhage, and it's in case of posterior vitreous detachment. These things can be identified much beforehand. We can give the prognosis to the patient. And optical coherence tomography is much more important in daily scenarios, because the expectations of the patients are too high. We may land up in visual surprises if the patient is not identified correctly. The patient may be having so many macular problems because of cataract. We may not be seeing those properly also. In this case, VMT is there. In this case, we can see diabetic proliferative retinopathy and central serous retinopathy, or we can see like macular telangiectasia, where the patient might be landing up in sub vision. So patient may be not happy after surgery. So we must rule out these things. As a take-home message, I want to say, patient expectations are at an all-time high. If you miss a problem beforehand, patient will assume that surgery is wrong, and surgeon might have done something wrong. And we must check everything so that we don't have refractive surprises, and we must check the macula, better option, so that we don't land up in visual surprises. And we should not withhold the OCT until something looks wrong at the slit lamp. Thank you, AIS, for giving me this opportunity.
Excellent presentation, Dr. Eswar. I have some queries regarding the blood sugar. How much should be the blood sugar before we operate? You have given the guideline of fasting blood less than 140. Yes, even some endocrinologists recommend if it is less than 200, you can operate. I want the panel to speak about it.
We do follow same fasting 140. Post lunch less than 200, not 180.
Suppose blood sugar is 160 or 170.
Yeah, we can operate, sir. And look at the HbA1c also. If the HbA1c is very high, about 11 or 12, probably you should not, because it means that at that time when you take the blood sugar will be 170. But if you take the 3 months average, you may be 11, 12. It's not a very good thing. So probably need to reduce it to about 7 or 8, and then.
No, I mean that 140 blood sugar strict. We should.
No, it's not strict. It's not strict.
It is not.
Less than 200 is the guideline.
One time blood sugar is not.
Suppose it is 160 or 170 or 180.
You can operate, sir.
You can operate. Less than 200, I feel.
Less than 200 RBS is the better option. As a guideline, we
there
do
is no cutoff level like that.
There is no cutoff level in it.
Yeah.
Second query I have regarding the syringing part. Is it mandatory to do syringing in all?
So it's a risk factor for endophthalmitis. Sometimes you miss the RO plus, so it's better option to do syringing.
Suppose RO plus is negative and you feel.
No, I do agree. I have done so many DCTs recently also.
Yes, sir.
So if the syringing is negative and the patient says only watering, no discharge, I opened the sac and sent for culture, positive.
Absolutely, sir.
Syringing is a must. If it is a negative, DCT is a must.
Yeah.
So otherwise, legally you have a problem. And I also, practically also, I have demonstrated there is an infection in the sac. The other thing I want to know from the panelist is the Xylocan test is a must for all?
Not necessary, sir.
Not necessary.
Not necessary. I don't do it, but.
I don't do it.
Yeah, I also
we do a large volume.
Yeah, I don't.
We have to see how much is the anaphylaxis rate. I think it's 1 in 20,000.
Yeah, no. Even then, there is no this thing, sir. Even the Xylocan test is positive. We do not know.
Guarantee.
There is no guarantee. So, but the syringing
if
is something which.
Also no guarantee.
Yeah. Whenever, see, please understand, when you see a patient with discharge in the medial canthus, or there is a MGD, or excess of watering, those patients, I think you should do syringing. But only thing is, don't do syringing on the day before surgery. Okay?
On the day of surgery.
On the day of surgery or one day before surgery
Day
also?
before is okay. On the
One-
day of surgery, no.
Normally we don't do that. When they come for a checkup, you do the syringing. So it's very important. Roplast is okay, but when you suspect and 1/8 patients, all that, we do a swab as well as syringing as well. Anyway, there are